the session 4. The one for
Okay. Yes, Prof, thanks. I think I just wanted to look at the one for carbetocin, as everyone is saying, just to understand. One thing is, if tranexamic acid is recommended for PPH within the first 3 hours, I don't know if we've had any suggestions to have this among the signal functions at WHO level to just reinforce its inclusion in the, to ensure that it is adhered to at your level. I think that's the question I had.
Francis, thank you, Francis, for the question. Any other? Yeah.
Okay, I think I got it that oxytocin is denatured when exposed to heat at a time. So I was just trying to imagine now that we may still need to use oxytocin for augmentation of labor. If it is denatured, does it affect that process of augmenting that labor also? And is there a possibility of putting like a VVM, like that, the ones we put on vaccines, so that it is able, we are able to know whether it has been exposed to heat and whether it can be used or it may not work?
Okay, I think, Professor, you should respond to the two questions.
So 2 very good questions. So Francis, in terms of the EMOC signal functions, so there's discussion to revise those ones now. I know they tried organizing a meeting, what date is this? Early this month, but I don't think it happened. I'm going to follow up to see with Dr. Alison Moran of WHO. So her department deals with this. So there's been a lot of concern that it's a bit out of date now. We need to refreshen it a bit. So I think this is a good suggestion. It's something that I can introduce to the discussions. Concerning the potency and the use of oxytocin, especially if we think it's denatured for augmentation, I think it's going to be similar, isn't it? So you find yourself using an increasing dose to have any contractions, even augmentation. But I mean, I think usually we are quite disciplined in terms of the dose we put in because we don't know whether it's working or not. And, so we're quite disciplined. So what will happen is that there will be more cases of failed induction and then a revert to cesarean section. That's the implication, essentially. Yes, so I think that's it's a near, maybe not exact Nobel Prize task now, is to find a test that you can determine the quality of oxytocin at the point of care. And if we can use all that knowledge from vaccine, for example, to be able to put this, to do this, I mean, that would be great. But I mean, I may be quite cynical when I think about why some people will not invest to finding those kind of solutions if there are alternatives. I mean, the pharmaceuticals, I mean, they run the show in terms of all of these things, isn't it? So, I don't know. So I think somebody really needs to push for us to do that. So we still need oxytocin. We still need oxytocin. Even if you make carbetocin the same price as oxytocin, you still need something to augment labor, isn't it? So I think it's still a challenge. I mean, no ready answers for that from me.
Those two questions. The next one was for confidential inquiry. Wow, we have questions there. So we'll take the two questions. Confidential inquiry. Okay. After confidential inquiry, you'll ask. Okay.
Thank you. Dr. Pamela, that was really good. Thank you. I just wanted to find out, of the 61% who died within 24 hours, what is the split between public and private, if we have that data available? And additionally, how has the rollout of CMD impacted the reduction of maternal mortality? do we have that kind of information, whether it's at facility level or at county level, even in a granular way? Thank you.
One more.
Thanks a lot, Prof. and Pamela. Now, mine could be alongside all those CMDs, but at whatever level. But first is to commend the great work that the team has done. The mention of the issue of the deaths that were reviewed by the AMO or the specialist is double-edged, not a sword. So don't look at it, because it only just shows that, yes, this death, because sometimes one can say that, okay, though they were reviewed by the AMO, though they were reviewed by the specialist, but they still ended up dying. The question would be, which I think you alluded to in the earlier presentation that I joined when you're on the floor, or earlier on, is that how many of all the complications that occurred in the maternity, how many were reviewed and then ended up surviving were reviewed by the specialists, by the AMO? I think that end is a bit gray. Okay, we don't have that data, but it would be good maybe in another study one can look at it, that of all the mothers that were admitted in the house, in this facility or in the facilities, how many received the reviews by the medical officer? Because they're assuming, because this is just a proportion of those who died. Yeah, so whether they have increased, it could be just that you have higher numbers. We get just like the same say when we say that the cesarean sections have increased. It is not, probably the counties have more, there's better access, and therefore the number has increased from 2% to 8%. But maybe because they have more access or better access. Two is that there's recommendations that Pamela you made, which I don't know whether were in terms of during the conclusion we talk about regional anesthesia and qualified or more experienced health workers. I don't know whether they were based on the findings or they were just these general statements that are being made, because I don't know whether in this analysis there was any evidence to show that those who were under GA were the ones who died more, or was there any comparison so that we make such a recommendation, or is it just an addition from other sources of other resource materials or source information? And the same applies to the qualified staff. Thank you.
Thank you, Dr. Okoro. Let me introduce him. He's Dr. Okoro from UNFPA. He came late. So we have that opportunity to answer those questions.
Yeah, so the 61% who died within 24 hours. No, we have not separated. We have not disaggregated that data, that public-private, but we have the data, so we can do that and see whether there is any difference amongst the public and private and FBO, NGO. The rollout of CMD and the impact on reduction of maternal mortality, that's a big one. That's a big one. So this process we started in 2015 using 2014 files, and then we went to 2015, 2016, almost close to the same time, reviewing those files. And the reports between 2014 and 2015, 2016, the result was somehow similar. 2018 is when we disseminated the report for the 2014 file. You see, we've been working behind, so we are kind of behind. So we are hoping the data that we have for 2019, 2020, which we have not reviewed yet, maybe it will show something different. Because now people are more aware, people are also having discussions within the hospitals on maternal deaths, and then we feel that the blame game is kind of reduced a bit. In most of the facilities, people are more comfortable to talk about maternal deaths, and the reviews are ongoing. So we hope that will come out in the subsequent data that we have, but that is what we are hoping for. Yeah, so we actually don't have that data to say there's been an impact as such. Then the MO special, I think this was a comment done about the MO and specialist, how many, the proportion of mothers who died, the proportion of mothers, we presented the ones who died but were reviewed by either medical officer or specialist, but I think it's something we can do to look at mothers who were among the mothers who had complications in specific facilities, those who were reviewed by MO and specialists, and they survived. So looking at the differences between the two, among the ones who died and the ones who survived, but they were all reviewed by medical specialists, and they had complications. Yeah. So I think that is information that we can. It's interesting information that we can look at. And then the recommendation was on regional anesthesia. I don't know whether that was my recommendation on regional anesthesia, but I think I also looked at that the Dr. Nelly's study when she presented her case control study, where she looked at women who had cesarean section. I don't know whether you had come yet. Yeah, we had a previous presentation where Dr. Nelly Pato, she looked at she did a case control study to look at women who had cesarean section, who died, and those who had cesarean section and survived in 2014 from KNH and I think KNH and Pumwani. So one of her conclusions was that the ones who had, there were some risk factors, and the ones who had underwent GA were more, the odds of them dying were more than the ones who did not have, because she did a case control study. So I think I had just referred to that study when I did the recommendation, the conclusion on my part. Yeah, I think maybe Charles, you want to add?
Thank you, Pamela. So just a few things. So most of the analysis you see in the confidential inquiry now, these are just descriptive analysis. You cannot make conclusions about causation. You cannot. At best you find an association, you set up a hypothesis, and then you plan to actually investigate. So the question, Dan, the research question will be, does the involvement of a medical doctor split by years of experience and training make any difference in the outcome? That's the question. So that's a separate research question. So now what you need to do is that you're going to take all the women who come for birth, and all of them, you classify them into reviewed by doctor, yes or no. If reviewed by doctor, level of experience, specialists, one group, MO more than 4 years, one group, MO 2 or 4, medical intern, if they reviewed, and then you look at the outcomes, and then you calculate the odds of death. And that will answer your question. So this, you cannot, from this data set, you cannot, any analysis you do now will be descriptive, but it's not going to solve that problem. But then the beauty of this type of thing is that now we know that we need to answer this because of the controversies it brings. Everybody suddenly goes into defensive mode, isn't it? So then maybe we need to do it properly. Then you have really, some information that you can work on. But just this type of analysis will not. So ideally, if you have a well-functioning confidential inquiry into maternal deaths, from this analysis, you can come up with questions and additional studies that will be funded, and you go through, you continue. That's what they do in the UK. There are sub-studies that will go on, for a good reason. So well-funded, well-functional, that is what should be happening. Yeah. And then finally, a question about the cesarean section. So if you look at the Lancet series on cesarean section 2018, there was this thing about too many too soon, too few too late. So what that means is that we have a low threshold for doing cesarean sections, A lot of them may not be medically indicated, not be appropriate. We've not waited enough to give the woman a chance. You know, there's nothing. Okay, I tell you now, just take 10 cases of cesarean sections from your facility or anywhere and look at the indication. I bet you 7 out of 10 is fetal distress. The remaining is lack of progress. What does that mean? Yeah, obstruct is just something, you know, randomly, you know, nobody knows what it means. So, you know, so too many, we do too many. Then for those, then too few, too late. You know, when you finally take a decision, you've taken the decision too late. There is a reason, but there's so many delays. Anesthesia, theater, transport, no blood, then finally you do it, it's a bit too late. Perinatal outcome, maternal outcome. So I think the objective, so from Nelly's presentation is, we should just have the right indication and you know, do things at the right time, and then that will make things better. Now, one of Nelly's slides may have been confusing. She was comparing 2 different things, apples and pears, the way she presented. She was talking about population-based cesarean section rate and institutional cesarean section rate. Population-based cesarean section rate is always lower. Institution is higher. You cannot compare the CS rate in Kenyatta with you know, the one they find out from the population-based survey. I mean, the difference is going to be really massive. So there are 2 different things. So population-based cesarean section rate above 10% does not lead to a decrease in perinatal and maternal mortality. That is the recommendation. That's the observation. It doesn't mean that Kenyatta should start to aim to come to 10%. That would be bad news, because they get all the, you know, very bad things. You know, it has to be. So they just need to make sure that they're doing for the right reasons and on time. Thank you.
Who has learned like we collect Cecilia section rate in our KHIS. I don't know which. So the session 6. You remember section 6 was on? Session 6, I mean, accountability framework, and that's for Professor Ame. Any questions? Introduce yourself.
Good afternoon, everyone, and I'll try to keep it very brief on accountability framework. I think as Prof was making the presentation, I kept thinking around how to involve the communities that are concerned, either through CBOs or other more formal channels, to be part of the accountability framework in a meaningful way. And I guess the question then is, how do we invest in such structures so that you have the voice of women really championing accountability for MPDSR. And then the second one, still around accountability, was having external facilitators. And I know this is more on the methodology for CEMD, but I see it a lot as part of the accountability framework, where you have external facilitators who are also mostly health workers who are looking at files from a health institution. So there's a certain language and a certain expectation. And I mean, this is a pattern that most of the external facilitators are like used to, and how this colors them or how it biases them in terms of giving objective reviews. And I think I've had a little experience as an external facilitator where you go into a facility, but they push back on you. They're always like, it's because you're not practicing anymore. It's because you're at national level. That's why you have these glaring eyes. And there's still a lot of shielding each other and trying not to have like the blame game. And so in all that, the question is, how do we have effective and truly objective support from external facilitators to strengthen that accountability framework? Thanks.
Okay, thank you, Dr. Ngoi. One more question for Professor. One more question for Professor. I want to give most.
Yeah.
Okay, so thank you very much for the presentations. And I think for me, in terms of MPDSR, I think one of the questions that keeps running through my mind is in terms of involvement of other sectors, even in this accountability mechanism. Like if we look at the leading causes of MPDSR, anemia is a leading cause, but nutrition, okay, in the whole, I think, discussion, we've not had discussions around what's happening with nutrition. Are we linking, especially when mothers come for ANC, and do we have any aspects that have been covered in the current program, or could they be considered for future programs, so that we then look at what multi-sectoral collaborations do we have in this response? Because when Prof, you were presenting, I think in one of the slides you said since 2014, up to 2021, we still have pending response. And that was the last line always, pending response, pending response. So how can we strengthen that to get meaningful results? Thank you.
Okay. Thank you, Esther, for your question.
Okay, thank you. My question goes to Prof, and it was about the heat-stable carbetocin. And if I want a clarification, if I heard you well, you said that it's not used to augment but it's used for PPH prevention. Yes, yeah, that's what I wanted a clarification on, and I think you have answered, because I was to ask if then it can be used for augmentation of labor, then we should do with the one that is bringing problems because of the temperatures and everything. Thank you.
Francis.
Thank you so much, Prof. I just want to dwell on the last part. I think this accountability framework for me looks marvelous, and I would wish that it's adopted for national level and even to the counties. I think mine is linked to Dr. Wangui's question on, now from your findings, who would you propose to be members of this accountability team, especially at national and county level, in your view? Thank you.
Okay, sorry.
Okay, thank you. So thank you, all very good questions. Let me start with a question from my sister Wangui. So how can we get the voice of women to help drive accountability? So I think if you had credible reports that have been scored and they have open access, and those women groups and all of that can look at those things and use that to demand quality and to ask questions, because they can say, you know what, this is not good quality, it doesn't work, you need to do better. Well, okay, yes, it's good quality. You now have stated clearly what you are going to do by when, but you have not done it. And they know exactly who they're asking the question. That is accountability. That's a mechanism that works. So I think it's if you put that tool in place, then that resource is available for people to ask questions. Then the use of external facilitators. So I hear you clearly, and medical practice is such a tribal thing, isn't it? We're all in different tribes, and I'm a midwife, I am a doctor, I am a specialist, I'm a clinical officer, and everybody is guarding their own. Seriously, you've purchased ultrasound machines, and now people are angling for, I'm the only one allowed to touch it and use it. Whereas all you're doing is basic ultrasound, for goodness sake. You're not doing anything fancy. Anybody can do basic ultrasound. Is there, where's the baby facing? Is the heart there or not, or whatever, basic stuff. Those machines, there's probably nobody, using those machines to full capacity. When you go talk about the guys doing fetal medicine, and then they're doing all sorts of crazy stuff, now we're talking. So why are people being so protective about those type of things? So back to the question, I digress and I apologize. So in terms of external facilitation, so if you get a healthcare worker from another facility going to attend the MPDSR meetings in another facility periodically, they're coming from outside, almost similar setting. similar level of experience. Maybe clinically they have the experience as well to work with the team to link some of the recommendations to clinical actions and training and things like that. So in that cluster randomized control trial that I talked about, the main thing, apart from the objective reviews, was also linking the recommendation to training, and then those external facilitators helping them through some of those actions. That was what made a difference. And that cluster randomized control was so good because the outcome measure was actually maternal mortality, maternal deaths, and it showed a reduction. So that was really good. So that's what I'll recommend in terms of that. But as usual, when we talk about these things, we need to look at the practicalities. You're talking about external people coming to join one facility and all of those things. Who's going to pay their transport? So there are those other questions which need to be, talked about. Then in terms of multi-sectoral collaboration, so recommendations and who is going to take the lead and making sure that recommendations are implemented, or some of the recommendations we can look into them in greater detail. So women are dying from PPH. So there are many things. If a woman comes into labor with a low HB for any reason, malaria, nutrition, chronic illness or whatever, that is something that needs to be addressed, isn't it? It's a different thing. She comes in normal HB, she bleeds, and there is no blood. They're all different things. So we need to look at everything. You cannot exclude anything. So for my team and the work we do in Kenya, so we have a separate program on antenatal, postnatal care funded through Global Fund, and we're implementing this in the same facilities we're strengthening with EMOC. So it's a whole continuum of care. So nutrition, they do all the nutrition things and all those type of things, postpartum IUD and all those. So, everything is covered. It's interesting. Tells you it's close to lunch. I can't even read my own handwriting. Esther talked about pending response. Okay, I think I probably have talked about it. Then heat stable carbetocin. Yes, so prevention only. Not for use for augmentation. In fact, there was a joint statement released maybe about 3 months ago by FIGO and all the partners, really to caution about the augmentation thing. So it has not been tested for use for augmentation. There are problems if used that way. And then thanks for your comment, Francis, about the accountability framework. So the question is accountability team and all of that. So like I said, just talking about the principles and the mechanism and all of that, somebody completely independent should be reviewing those outputs that are compiled as reports and putting a score on them. And then other people should be asking the questions based on those reports. It may be somebody in leadership in the Ministry of Health at county level and all of those things. But then this will make everybody sit up at different levels. Nobody wants their score to be the same time after time. If I was the leader at some level, I would say, this is now a joke. We are not seeing no improvement. Okay? So all we need to do, if this system is adopted, there's an independent group that is doing it. So for example, just an example, if in Kenya you say, okay, say the Ministry of Health says, okay, we give this contract for independent review and scoring of all reports to, just for example, University of Nairobi for the next 4 years. Their TOR is to review all these reports that come out from the counties and, against this framework and score them independently and put them in a central place anybody can check, anybody can see. So that's how it will now, snowball to improving actions. So for now, it is all conceptual, I don't know when this will ever, anybody will take me seriously, but that's the only way. Otherwise, I think in 10, 15 years' time, we are still doing MPDSR. We may even add another letter to the thing. Nothing is happening. Nothing is going to happen because there's nothing driving us to want to make a difference. Okay. So I think we may be at the risk of missing lunch, but.
Okay, Pamela, you want to say something?
Not much. Maybe I can just reiterate the comments that were made yesterday by one of our guests, the governor of Vihiga, when he said that two most important things. that are needed if you want to bring about change within your area. Top leadership support, commitment and political will at the leadership level. And 2, legal framework. Legal framework for anything that we do. I think that has also been a challenge within the MPDSR process. I remember when Dr. Wangwe and I were still working closely together before she ran away. We tried to have the National MPDSR Committee gazetted, because the committee members felt they need some legal understanding, legal identification, on their roles and responsibilities. So we tried to have that committee gazetted officially, but we hit a snag somewhere in the Ministry of Health legal office because we were being asked, you want this committee to be gazetted, where is the legal reference point that we need to refer to as we gazette this committee? So we hit a snag there. And something that has been done legally, it goes, resources follow it, So the good political will and also a strong legal framework. Thanks.
Okay, thank you, Pamela. I don't know what advice you'll give us now that you're exiting the arena, maybe not totally on that legal framework. If you hit a snag and still it is being recommended, what do we do? So with that homework for Pamela. Okay, we'll still explore that. I think eventually we'll have something to make us do better. And for Professor, we've added an end to the MPDSR, maybe for Kenya, because we want to have the perinatal and neonatal audits in the same. So that is under discussion. So we are adding. We don't have to wait for 16 years. So with that, we're going to give everyone who presented, anyone who asked questions, all that participants will give ourselves 4 factorials. And we begin now. Tuanze. 1, 2, 3, 4. 1, 2, 3. 1, 2, 1. Good appetite.